Hi all, Jan Louis van der Berg. Just to summarize the workflow before arriving at our tensioner technique. Workflow would then be a restricted personal tibia cut first, followed by femoral planning, which is then hybridizing measured resection, then gap balancing, limb alignment and shape matching. Tibia planning first, of the utmost importance. So arriving at our proposed restricted kinematic alignment values, I would be accepting a MPTA of 4 degrees varus to 2 degrees valgus. Reason being, if we look at the normal variances, I know there are many studies, but looking at Bellemans specifically, of his 500 knees that he depicted, MPTA varying between 0 and approximately 6.5 degrees of varus. Secondly, we look at the kinematic alignment data which has been published by Howell, 98% 10-year survival, and he was happy to have an MPTA from 8 degrees varus to 6 degrees valgus. It's depicted here. Thirdly, Pagnano is willing to settle for 3 degrees varus to 3 degrees valgus with his new talk, Can We Safely Explore a New Paradigm? So our proposed restricted kinematic alignment acceptable value on tibia side would be MPTA of 4 degrees varus through to 2 degrees of valgus. Next we look at the posterior slope considerations. Normal patient variability is taken into account, and we look at Weinberg and Ma et al.'s work, 7.3 plus minus 3.8, and we look at the ethnic differences. Chinese, for instance, much more, 9 plus minus 2.5. The first thing all of us, after considering this, asks is what is the reasons for failure. So tibia component failure is our consideration. Now we look at Nedepol's work, taking the kinematic group, 3,200 primary knees, and interesting, we would have thought that the varus valgus outliers would be the reason for failure on the tibial side, but it is not. It is actually the posterior slope or posterior subsidence, posterior edge wear, that is the reason for a tibia component failure. And again, interesting, if we look at the mean posterior slope of the series, it was 11.2 degrees, plus minus 3, which in our minds is too much. However, the posterior slopes that failed were the ones where the posterior slope was 5 degrees in excess or greater than the controls. So I proposed a restricted kinematic alignment. Acceptable values on the tibia side would be MPTA 4 degrees varus to 2 valgus and the posterior slope 0 to 8 degrees. We then go forth with our tibial resection. We prepare the site, and once the tibia has been cut, we come to our stress range of motion collection. This is a very important topic for me. So looking at tensioning, the goal I would put as arriving at a balanced soft tissue envelope after a total knee arthroplasty with an acceptable range of anatomic variances with minimal soft tissue release performed. Considerations would be personal laxity, and Roth have a good paper on the personal laxities of patients, and here we can see On the lateral side between 3 to 4 millimeters, and on the medial side 2 millimeters between the native ACL and the kinematic aligned knees. Secondly, we look at the bony pathology, the morphology of osteophytes, and then thirdly, the soft tissue contractures and acquired laxities. These will all have an influence on our tensioning. Cruciate ligament influence is an important factor, and the first question everybody must ask himself is the effect of posterior cruciate ligament resection predictable? And the answer is Schnur and Koenig did a study and found that the flexion gap is increased in many cases after posterior cruciate resection. Many times not, but sometimes as much as 9 millimeters. And personally, I think they underestimated sometimes even more. Second consideration would be the cruciate ligament influence, as the flexion gap can increase if the ligament is resected. Therefore, if that is true, then the tibia in flexion is suspended or hangs on the posterior cruciate. Therefore, if you use a bitensioner with variable tensioning forces in flexion, it could toggle in flexion through to extension and would not give a totally accurate reading. However, increased distraction tension force also enlarges the flexion gap as the PC is more vertically forced. This is according to the article by Jan Victor in 2017. There we see it, and also translation of the tibia anterior relative to the femur as forces increased. Timing of the tensioning procedure is also of utmost importance, and it is maximized. Accuracy can be maximized by controlling as many factors as possible that could influence the outcome. Therefore, before tensioning, osteophytes are removed around the femur and tibia, as well as the menisci. The loose capsule subperiosteally is loosened, and then we are ready to perform the personal restricted tibia cut, which we have performed already. Question of bitensioning or monotensioning. Bitensioning, as discussed, could toggle in flexion if the posterior cruciate is still intact. Monotensioning has always to be relative to the contralateral side, so evaluation of the contralateral side is important. If it is deranged or pathological, it will give an inaccurate reading. But if it represents the restricted personal tibia joint line, it will result in the most accurate tension reading. Acceptable tension force, this article by Jester Beek and Ritchie, they used a tension force of 80 newtons in their paper, although they suggested one a little bit less. Hand-stressed range of motion. Our problem is it does not reliably reflect the ligament tension, because valgus varus stress applied in extension and flexion is influenced by hip rotation, and therefore it's not constant. It's confounded by the osteophytes and soft tissue structures. The solution would be differential tensioning. You do your restricted native constitutional tibia joint line cut, you have a stable platform, followed by a constant and a reproducible stress throughout the range of motion by a ligament tensioner. So this is our differential tensioner. On the one hand, we have a lever arm and a torque wrench. Here we have a calibration screw, and we can calibrate how much force is eventually produced by our flexi blade. We have a left flexi blade, a right flexi blade. By simply moving the gear across, we can either drive the right hand blade or we can drive the left-hand blade. So, to tension a side, we simply remove the one flexi blade and then we insert a spacer which represents the joint line. We thus place the tensioner into the flexion space and toggle our torque wrench until we have a constant force of 80 newtons. Once it toggles, we have 80 newtons. Therefore, on the one side, joint line, other side, 80 newton, and we can take it from flexion through to extension. Now we reconfigure our tensioner. We remove the spacer, and now we insert the flexi blade on the left side. We move our gear across, remove our flexi blade from the right side, then we simply insert the spacer on the right side. So now we have a joint line on the right side, a flexi blade on the left side. We insert this into the flexion space and we toggle it until it clicks. Once it clicks, we again have a constant 80 newtons force. Take it through the range of motion, flexion, extension, and our tensioning medially and laterally has been done relative to a constant joint space. So here we have the operation procedure, our tensioner placed in the flexion space, and we can see in this instance a XR knee with the rigid platform on the left side and the tension or flexi blade on the right side. You can also see the torque wrench just sticking out on the right side. There we actually toggle the torque wrench and create our constant 80 Newton of tension in the flexi blade on the right side. We now take the knee through its range of motion. Then we reconfigure the tension blade by changing the rigid blade to the right side and a flexi blade to the left side. So finally we come to the femoral placement planning. No changes are made to the tibia planning screen as the tibia has already been cut. We now hybridize our femoral placement through measured resection, gap balancing, limb alignment and shape matching. We come with our final implant planning and we can do the numbers, see that measured resection is, we can tick the box, and we can tick the box for shape matching, we can tick the box for our gap balancing, and our limb alignment on the right hand side we can also tick the box. Thank you.